Okay, so I think this is a very important question. So for about the diagnosis before the treatment by the ablation. So I think, so we need a tissue diagnosis, but what is your practice? So we do the FNA or we do the core biopsy for the benign or the for malignant, maybe they have a different situation. So can you share this to us?
So certainly if a patient comes to me with a follicular neoplasm that still wants to do ablation, I take a core biopsy. But do keep in mind that your pathologist may be very irritated with you because they are not used to reading core biopsies of the thyroid. For malignancy, I just do an FNA because yes, in proven malignancy that recurred, I just do an FNA. I just want to show this a recurrent PTCA and move on.
I agree with Dr. Do, because for the benign nodule, I think the most important is to make sure the ultrasound appearance of the target nodule that do not show any suspicious sign, because for the benign symptomatic nodule, usually it's very big. Even we perform many times fine needle aspiration or core needle biopsy, we cannot 100% guarantee the nodule are really benign. But the most important is the nodule should not have any malignant suspicious sign. But for the benign, for the metastatic lymph node or recurrent lymph node, we just perform fine needle aspiration to make sure that they are really malignant nodule. And also for follicular neoplasm, if the patient really want to receive ablation, I usually perform core needle biopsy, because as Dr. Do has mentioned, it's very difficult for a pathologist to use fine needle aspiration to make the diagnosis of follicular neoplasm. But I think fine needle, core needle is also okay. Yeah.
Okay.
I think the major concern for the patients with papillary thyroid microcarcinoma is the preoperative diagnosis, because some of them may have indeterminate cytology, but with a positive testing of BRAF mutation. So these patients commonly clinically was regarded as papillary thyroid microcarcinoma. However, these patients want to have a pathologic report and medical insurance. So sometimes I perform biopsy, only like 40 to 50 can have a diagnosis. I have a surgical diagnosis with biopsy. I think this is very difficult for document diagnosis for papillary thyroid microcarcinoma.
Okay, so what about the Dr. Giovanni? So any comment for the biopsy or the FNA before the treatment?
I think Dr. Giovanni went into an operation. I'm not sure if he's here.
Okay, that's fine. So thank you.
Dr. Xu, you're breaking off. Your sound is breaking off. I think there's a connection problem.
Yeah, the signal is not so low.
Yeah, it's a bit unstable.
Yeah. Okay, so let's move on to the. So I think this is maybe the one of the challenging questions. So they ask what is the biggest size of the nodule that we can ablate it? So do you have the size limitation for that? Maybe both three of you.
I've done 8 centimeter before.
Wow.
Yeah, so you can see the nodule from the patient's back, but now he's almost flat, and I broke 2 needles doing him because I was trying to bend and everything. So I was ablating, and suddenly it's like, hey, how come there's water coming out and splash on my face? Like, oh, I've broken the needle, and that is a cooling. But you can do quite large lesions. You can do retrosternal lesions as well. So after ablation, then the retrosternal part comes out and you ablate them again.
So how many sessions you have to do for the
2. The boy, the large one once, amazing. I finished him in 1 session.
Oh my
God. He tolerated all 8
right.
centimeter. I couldn't.
It's quite good. The maximum diameter I was down was I have the ablation is 11.
11. Okay.
11 centimeter. It's quite large.
That's big.
And I think the major concern for our clinicians to perform the ablation, some ablation is in some older patients. You have to worry about their breath function, because even a small nodule with some ablation, the patients may have a decreased oxygen saturation. It occurs in the surgery. You have to be prepared well before you perform the ablation.
Okay, thank you. So I think this is one of the important question is about the anesthesia. So I believe most of the procedure performed by under the local anesthesia. So, and do you have any technique to do the adequate anesthesia, or any of you have to use the light sedation combining, or you just do only the local only?
I think for benign synovial nodule, local anesthesia is totally enough for the patient, but for some very big, but I think it's okay. But if we want to perform a procedure for quite a long time, usually the patient will complain because they have to keep lying down for quite a long time. It depends on the patient, but for my personal experience, local anesthesia is totally no problem for thyroid IFA or microwave.
Yes.
Okay.
At least 30 minutes. I think the patient may be okay with one injection of lidocaine for local anesthesia.
So no need any painkiller during the procedure, the fentanyl or?
I think it's
not necessary.
Not necessary. For benign nodule, usually the patient can tolerate the procedure, unless we really perform the procedure for quite a long time, or sometimes in some very huge nodule. But I will discuss with the patient. Maybe we can use separate section, but it means the patient will pay extra money for the procedure.
Okay, that's a good point. So I think this question is come from the surgeon. So he asked about how good of the experience in the ultrasound that need for the surgeon before perform the ablation. So maybe Dr. Xu can give us the comment.
Would you like to repeat your question? I'm sorry.
So how good of the experience in the ultrasound before starting the thyroid ablation?
This is very important. That you should have enough experience with ultrasound. For me, as an endocrinologist and the internal physician, I think it's really hard for me to initiate to start this technical treatment. Before I start microwave ablation or radiofrequency, I have done like 2,000 fine needle aspiration. I think that this should press more with fine needle aspiration, and then maybe you can easily learn how to perform microwave ablation or radiofrequency ablation.
Okay, so can you tell us the number again that you have experienced before? I mean, before starting the procedure.
Yes, before I start some ablation, I have done like 2,000 cases with fine needle aspiration. It's very easier for a physician, you know.
Yeah, okay, that's a lot. 2,000, right? So, but that's a very good thing to start with the FNA first. So, and give us the information about the ultrasound finding. The one of the very important is not only the FNA, but we have to combine the knowledge of the ultrasound finding suspicious characteristic of the nodule with the FNA result and before performing the ablation, I think. Okay, thank you.